Good morning, and welcome to this meeting of the Physician-Focused Payment Technical Advisory Committee, also known as PTAC. My name is Dr. Chini Puluru, and I'm one of the co-chairs of PTAC, along with my colleague, Dr. Lee Mills. Since 2020, PTAC has been exploring themes that have emerged from stakeholder-submitted proposals over the years. Previous PTAC-themed discussions have focused on topics such as reducing barriers to participation in alternative payment models and supporting primary and specialty care transformation, encouraging rural participation, using data and health information technology to transparently empower consumers and support providers, and improving multi-payer alignment in value-based care. At this public meeting, we have brought together various subject matter experts to gain perspectives on targeting improvements in patient safety through alternative payment models. We know that this topic is also of interest to the Office of the Secretary at HHS and the CMS Innovation Center. Before our first session of the day, we are honored to have opening remarks from Mr. Samuel Waters, Counselor in the immediate Office of the Secretary at HHS, and Mr. Abe Sutton, Director of the CMS Innovation Center and Deputy Administrator at CMS. Mr. Waters' portfolio includes the Center for Medicare and Center for Clinical Standards and Quality, the Center for Program Integrity, and the CMS Innovation Center, as well as the Agency for Planning and Evaluation. Guided by a commitment to patient safety, his work at HHS centers on redesigning payment incentives and coverage policies to drive sustained investment in safety and quality across healthcare settings. Mr. Sutton, prior to assuming his current role at CMS in January of 2025, served as a principal at Rubicon Founders, where he co-founded two health service companies, Honest Health, which focuses on enabling primary care physicians, and Evergreen Nephrology, which focuses on enabling nephrologists. From 2017 to 2019, Mr. Sutton also served at the National Economic Council, Domestic Policy Council, and the Department of Health and Human Services. In these roles, he coordinated health policy across the federal government with a focus on value-based care, increasing choice and competition in healthcare markets, and updating the federal government's approach to kidney care. First, we welcome Sam to speak, and then we will move to Abe to share his remarks. Sam.
Thank you very much. Good morning, and thank you all for being here. Thank you to the committee and the co-chairs. Thank you to Secretary Kennedy for allowing us to move forward with this topic for a PTAC. I had an opportunity to share a personal story with him that I'll share with you all in a moment. That really resonated, and he's given me agency to be able to move forward with refocusing on this extremely important topic of patient safety, as well as Dr. Mehmet Oz at the Centers for Medicare and Medicaid Services, and Abe Sutton as well. We've all had, I think, really positive conversations about today's meeting. I want to thank Cindy Goss in the Assistant Secretary for Planning and Evaluations Office for helping coordinate this, and Steve Scheingold as well, who put a tremendous amount of effort into today's programming. So as I said, before I begin, I want to share a personal experience that brought the issue of patient safety from the realm of policy into something profoundly real for me. This is the one part of the speech that I was unable to write. Brianna Bauer was 25 years old. We had been dating for a little over 2 years. She was a third-year law student at Pepperdine University. On November 15th, 2024, she went in for a very routine medical procedure, and due to substantial problems and mistakes and every breakdown that you can imagine happening from the point that the mistake was made on, she was given way too much lidocaine, and she suffered lidocaine toxicity. And they didn't catch it. She started to have uncontrolled seizures. She went into cardiac arrest, which they didn't catch. When they transferred her to a hospital, they hid the reality of the situation. She didn't get the appropriate care that she needed. She spent 7 hours with uncontrolled brain swelling, and they ended up having to transfer her to UCLA just to save her life. She suffered severe anoxic brain injuries, and she is unfortunately in a persistent vegetative state that I think she will likely be in for the rest of her life. I was lucky to have worked in the first Trump administration at the Agency for Healthcare Research and Quality, and so I saw all the tremendous work that people who are passionate about patient safety do. But really, until this happened just about a year and a half ago, it had never hit home to me as profoundly or as heavily as it did. That drove me to want to come back into the department and make patient safety my North Star. And I think many of you have had an opportunity to have a conversation with me and really have heard my passion for it and have helped me advance this and drive this issue forward. So I thank everybody really for being here today, and I hope that we can make something substantial out of this meeting. Because, unfortunately, stories like mine are not rare. More than 25 years ago, the Institute of Medicine's landmark report, To Err is Human, estimated that tens of thousands of Americans were dying each year from preventable medical errors. The report launched a patient safety movement that has produced important advances. We have better infection control practices, stronger reporting systems, safer surgical protocols, and a far greater awareness that harm in healthcare is not inevitable. And yet, if we're honest with ourselves, the results have fallen short of the aspirations. Today, patient safety remains one of the most significant challenges facing American healthcare. Recent evidence suggests that preventable harm continues to affect millions of patients, imposing enormous human and financial costs. A major national study published in BMJ Quality and Safety estimated that approximately 795,000 Americans each year suffer permanent disability or death because of diagnostic errors alone. Diagnostic error remains one of the leading causes of preventable harm in the United States, yet it is still inadequately measured and insufficiently addressed. At the same time, new reporting data from the nation's largest patient safety reporting database found that serious events and high harm events increased nearly 10% from 2023 to 2024. Other analyses suggest that some of the gains achieved before the pandemic have eroded under the pressure of workforce shortages, burnout, growing complexity, and fragmented systems of care. The cost is measured not only in lives altered and lost. Preventable harm is also a major contributor to healthcare waste and inefficiency. We spend hundreds of billions of dollars each year on care that does not improve outcomes and, in some cases, actively causes harm. Every preventable infection, medication error, misdiagnosis, fall, or surgical complication represents both a human tragedy and a failure of stewardship of public resources. This reality should compel us to ask a difficult question. Why, after a quarter century of national effort, are we still struggling to achieve meaningful reductions in preventable harm? Part of the answer is that our approach has often been fragmented. We have created reporting systems without learning systems. We have created measures without timely feedback. We have often focused on compliance rather than improvement. And too frequently, we have measured what is easy to count rather than what matters most to patients. Another challenge is that we have sometimes created environments where fear of punishment discourages transparency. Accountability matters. Patients deserve accountability. But patient safety advances when organizations are willing to surface problems, learn from them, and share lessons broadly. A system that is perceived as purely punitive risks driving harm underground rather than bringing it into the light. We should strive for a culture that balances accountability with learning, transparency, and continuous improvement. That is why this moment presents such an important opportunity. For the first time, we have technologies capable of helping us detect harm at a scale that was previously unimaginable. Artificial intelligence, large language models, and advanced analytics can help identify safety events hidden within millions of clinical records, uncover diagnostic errors, detect emerging risks, automate quality measurement, and dramatically reduce the burden of data abstraction. AI can help level the playing field so that sophisticated safety surveillance is not limited to a handful of elite institutions, but becomes available across the healthcare system. We must also recognize that AI itself introduces new risks. Algorithms can miss critical information, AI-enabled documentation tools can propagate inaccuracies, clinical decision support systems can create new forms of error, and electronic records themselves have become sources of patient harm when poorly designed or poorly implemented. As we embrace AI, we must apply the same rigor to evaluating its safety that we apply to evaluating any clinical intervention. Our challenge, therefore, is not simply to adopt technology, it is to build a modern patient safety ecosystem that combines transparency, measurement, culture, human-centered design, and innovation. Imagine a future where we can identify harm in near real time, where patients have a meaningful voice in safety reporting, where quality measurement reflects actual patient outcomes rather than outdated claims-based proxies, where hospitals are rewarded not only for avoiding harm, but for how effectively they recognize, disclose, and learn from mistakes, and where every agency across HHS is aligned around a single goal, moving the nation toward zero preventable harm. That is the opportunity before us. The work of this committee can help shape payment models and policy frameworks that move patient safety from an aspiration to an operational reality. We have the knowledge, we have the technology, we have the evidence. What we need now is the will to act with urgency. Because behind every statistic is a person, a family, and a story, and they deserve a healthcare system that is committed to safety as it is treatment. Thank you.
Abe.
Thank you, and thank you to the co-chairs, to the committee, to the ASPE team for organizing this, and for everyone listening in today for this important conversation on the topic of patient safety. It's a privilege to join you all today. I was last here in September, and I spoke about the 3 strategic pillars that guide our work at the Innovation Center, touching on evidence-based prevention, touching on choice and competition in healthcare markets, and touching on empowering people to achieve their health goals. The truth is, the patient safety is core to each of these 3 pillars. And without safety and trust in the healthcare system, it is hard to engage and navigate and know where to turn. Before I dive in, I just want to recognize the incredible and inspirational work that Sam Waters has done. It's a privilege to be sitting with you here, Sam, and to get to work with you to move forward this mission. Your focus on patient safety has been unwavering, and we would not be where we are today, having advanced the ball without the work and focus that you have done. I know that your story and your strength is an inspiration to all of us in this work, and so truly thank you, Sam. Sam plays a critical role as a counselor to Secretary Kennedy, and as giving policy advice in that role. I know it's been an incredible partnership where we work together on advancing the ball on many innovation center models, advancing the ball on the topic of patient safety in our work, and really playing a pivotal role in a number of areas, including the Secretary's nutrition initiative. And so it's a privilege to join you today and to join the PTAC today. Patient safety and the Innovation Center strategy. The truth is that patient safety is really embedded in each of the pillars. When I think about evidence-based prevention, prevention includes preventing harm. A foundational principle for doctors in our healthcare system: do no harm. If we could improve the efficiency and reduce unnecessary utilization that may actively be harmful to patients, that is a good thing to do. That is the core philosophy behind our WISER model, which focuses on areas of low-value care that may actively pose a risk for harm and truly embody waste in our system to prevent that unnecessary utilization. Attention on services where there is evidence of overutilization is critical. Patient safety concerns, inappropriate utilization, let's prevent them on the front end. Turning to our second pillar, on patient empowerment. Patients have the information and the tools necessary to engage in safe care, to know where is a system that they can rely on, where are their safety records and track records, where are the risk of infection. That information needs to be accessible, and we should strive to eliminate the harm. Transparency and informed decision-making. is the key principle behind this pillar. I would highlight our lead model and our access model as two models that embrace this. If I think about LEAD and its structure of accountable care organizations, information accessible to people and people choosing where to go in the system, primary care physicians partnering with patients to help them navigate with downstream providers in the system, and then our access model, which is geared really around patients choosing from consumer-facing technological solutions, digital therapeutics, the one that is right for them, the right that supports them, will help them navigate the system and achieve the results they are looking to achieve within it. Finally, choice and competition. You should be able to choose providers and care models that deliver the best outcomes. Competition works best when patients, providers, and payers have access to meaningful information. You cannot get there if you do not have safety results included in that. That has to be part of every scorecard that you put together. If there's a risk of infection, of a hospital-borne illness, that is not the experience you're looking for in the system. That poses a real risk of harm. Now, when creating the right incentives for providers to compete on value, including patient outcomes, experience, and safety, not simply volume, are part of the equation. It changes the incentive structure for providers as they engage with the healthcare system. The Innovation Center's authorities go beyond allowing us to engage in the way that the statute lays out based off how regulations can implement the statute to support fee-for-service incentive structures within our system. So there's more flexible approaches, more nuance in how we could design care pathways, reacting to information as we see it. That's important. That's one of our goals. That's something we embrace. As part of that, we monitor patient safety outcomes. We monitor patients' experiences as part of preparing model evaluations. If there is a spike in sepsis as part of the incentives we've designed for a hospital system, that's something we need to learn from, reflect, and redesign to ensure that doesn't occur. In the alternative, if we are effective at resetting the quality incentive because suddenly you're looking at avoiding readmissions within 30 days post-discharge, then we can see more of a focus on upfront investment in avoiding these hospital-borne illnesses. We also are looking to test how technology can reduce burden on providers and increase patient quality. I mentioned the access model earlier. I could similarly mention the Aspire model, which is one that is going to focus in Medicaid on pediatric high-needs populations and try and change the incentives to interact with that population, including giving them support 24/7 so that they can avoid ED utilization. How can we engage with populations, meet them where they are, and prevent issues from compounding as they engage with the healthcare system? You go in for a routine visit, and you come out with something much worse. That's not the bargain we anticipate for when we go into the hollowed halls of a medical institution. Working to align incentives around evidence-based care and patient outcomes rather than volume is our mission at the Innovation Center. Now, today's agenda highlights the importance of leadership accountability in patient safety. Improving patient safety requires active leadership engagement so that resources and attention are focused on this important issue. Clear accountability, measuring the progress that is made, and holding oneself and one's teams accountable for the lack thereof or for what is improved. The meaningful measurement aspects. And finally, sustained investment to make progress on those aspects in people, systems, and technology. The truth is that we're at a moment where more can be done in terms of measurement than ever before. The cognitive ability to track different aspects and see measurement and prioritize and stratify between them has never been more accessible. That's only true at some systems, though, and encouraging the deployment of tools and measurements so that safety is centered in a patient care experience is critical. And we hope to set up the right incentive structures to enable the adoption of these tools and supports throughout the system. Across our models, we will continue to explore how payment and delivery can support these goals. And I hope that the conversation today and tomorrow will shape that approach going forward. Looking ahead, as we think about patient safety, we think about better measurement. How can we meaningfully measure patient safety outcomes? What is the right metric to focus on, and how do we draw the right conclusions from it? What are the actionable metrics that matter to patients and providers where change can be made quickly to drive improvement? How can we use technology in a smarter way? I've mentioned the access model, but how can we scale payments with outcomes? What would it look like if we think about remote patient monitoring and the right incentives to come into play in that space? What would it look like to have earlier identification of safety risks and opportunities for improvements and to act on them and track that and reward the action? Finally, better incentives. Models that reward quality, continuity of care, coordination, evidence-based care. The partnerships that we have in the Innovation Center with entities like ARC, with our colleagues in CCSQ, with the ASPE team and the PTAC, with clinicians serving patients, patient advocates, healthcare systems, and other stakeholders really help ensure that we're focused on the right safety innovations and improvements that are transparent so people could learn about them, see them, and understand it, measurable, so that we see, okay, this is real or this is not, and then truly they are patient-centered, so that we are grounded in the experience of the patient as they engage with the system. The PTAC is going to continue to play an important role in shaping physician-focused payment models, and we are grateful for the partnership and input that you provide to us. The key questions that I would pose for this group, where I'm hoping to get insight over the next 2 days, are how do we measure safety in value-based care? How can technology improve safety in ways where we see it as additive rather than as distracting from the care experience? And how should payment models create opportunities rather than risks as we think about this question? I look forward to learning from today's discussion, and I know my team does as well. Thank you.
Thank you, Abe, for your thoughtful words and work in developing policy to improve health care. And thank you, Sam, for showing us the importance of this and sharing a very personal story and surfacing this for us today. We appreciate your support and engagement and look forward to collaborating with the Office of the Secretary at HHS and the CMS Innovation Center. For this public meeting agenda, we will explore a range of topics on targeting improvements in patient safety through alternative payment models that include approaches to improve patient safety in alternative payment models, measuring patient safety in value-based care, improving safety in value-based care through the use of health information technology and data analytics, payment mechanisms and financial incentives to encourage patient safety in alternative payment models. This public meeting will focus on examining how patient safety can be improved through alternative payment models and how the development of new safety performance measures and new technologies can help further improve patient safety. The background materials for this public meeting, including the environmental scan, can be found on the public meeting registration site and will be posted online at the ASPE PTAC website's meeting page. Throughout the meeting, we will hear from many esteemed experts with a variety of perspectives. I also want to mention that tomorrow morning we will include a public comment period. Public comments will be limited to 3 minutes each. If you would like to give an oral public comment tomorrow but have not yet registered to do so, please email PTAC, PTAC registration at norc.org. PTAC registration at norc.org. Again, that's PTAC registration. The discussions, material, and public comments from this public meeting will inform a report to the Secretary of HHS on targeting improvements in patient safety through alternative payment models. Over the next 2 days, the committee will discuss and shape our comments for this upcoming report. In April, we posted a request for input on the ASPE PTAC website to give stakeholders an opportunity to provide written comments to the committee on targeting improvements in patient safety through alternative payment models. To date, we have received 3 responses that the committee may consider during their discussion over the next 2 days. I would also like to note, as always, the committee is ready to receive proposals on possible innovative approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters, allowing flexibility depending on the level of detail of their payment methodology. You can find information about submitting a proposal on the ASPE PTAC website. At this time, I would like to invite my fellow PTAC members to please introduce themselves. Please share your name, your organization, and if you would like, feel free to describe any experience you have with our topic today. I'll start. I'm Chini Puluru. I'm a family physician by trade. Currently, I'm the Chief Medical Officer of Agentic Healthcare, which is a vertically integrated health tech company to deliver an individual access promise to provide patients with agency not only over their longitudinal health records, but to deploy specialized AI agents to take action on behalf of them and their families. Prior to that, I served as Chief Clinical Executive at Walmart Health, where I led, among many things, the patient safety organization for the pharmacies across Walmart, as well as led healthcare operations between Walmart Health and the telehealth platform. And prior to that, I served as Chief Clinical Executive for DuPage Medical Group, or Dooley Health and Care, where I led all things clinical care delivery, of which their risk management platform was one, as well as their patient engagement platform. Now I'll hand it over to Lee.
Good morning. I'm Lee Mills. I'm also a family physician. I currently serve as Chief Medical Officer of Aetna Better Health of Oklahoma, one of the state's 3 contracted Medicaid managed care organizations. I came up through medical group, integrated health system, and ACO operational leadership, and have the privilege of having led and operated on both the provider side and the health plan side through 6 CMMI models over the years. In my current role, we're under the interesting legislative and contractual mandate to increase the total dollars spent under value-based contracts to more than 50% of all dollars spent through managed Medicaid over the next 3 years in Oklahoma. So, next.
Thanks, Lee. My name is Krishna Ramachandran, Chief Information Officer for United Healthcare Operations and Experience. I've been in healthcare for 24 years in the technology, provider, and payer perspectives, furthering value-based care. Lindsay?
Thanks, Krishna. Good morning. I'm Lindsay Botsford. I'm a family physician in Houston, Texas, where I continue to care for patients, including Medicare beneficiaries. I also serve as a regional medical director with One Medical, part of the Amazon Health Services family, where I support our practices across the Midwest and Texas. I also chair the governing body of Iora Health Network, which is our direct contracting entity in ACO REACH for the last 4 years. Prior to this, I've worked in large health systems and teaching faculty roles in a variety of VBC models, including patient-centered medical homes and MSSP. David.
Good morning, David Tyson. I'm the Senior Director of Policy and Regulatory Affairs at Novant Health, which is a large integrated delivery network spanning the Carolinas. I help the system navigate all things patient safety, quality, value-based care regulations, and then previously to my current role, used to help lead our system ACOs and the MSSP specifically. Walter.
Thanks, David. Good morning, everyone. I'm Walter Lin, founder of Generation Clinical Partners. We are a medical provider group in the St. Louis area focused on caring for the frail Medicare beneficiaries living in senior living settings. We have participated in a number of different value-based care initiatives, from bundled payments to MSSP to institutional special needs plans, PACE programs. I currently serve also as the Chief Clinical Strategy Officer for LTC ACO, which is MSP long-term care focused ACO.
And now we'll go to our virtual members, Lauren and then Larry.
Good morning, I'm Lauren Harden. I'm a nurse by training and Chief Integration Officer for HC2 Strategies. HC2 stands for Healthy Connected Communities, and our work is deeply focused on building coordinated approaches for complex populations. We're also deeply involved in quality incentive initiatives across the state of California with health systems. My background includes leading care coordination in multiple ACOs and value-based payment models. I was part of the team that established the National Center for Complex Health and Social Needs, working with states, communities, health systems, community-based organizations on design of initiatives to improve appropriate utilization, quality, and safe care for complex populations.
I'm Larry Kaczynski. I'm a gastroenterologist by training. I practiced for 40 years in the Chicagoland area and built the largest GI practice in Illinois, the Illinois Gastroenterology Group. I also have significant experience on the hospital side, having sat on a hospital board for 10 years. So patient safety is something I was involved with at the ground level. I'm also a serial entrepreneur, having started a company named Sonar MD, which has built value-based care solutions for gastroenterology and was one of the first PTAC recommended physician-focused payment models back in 2017. I currently have a position as a fractional CMO for an AI-powered microbiome company named Jonah. But most recently, most of my energies are spent with my latest startup called Viovac, which is a company built around an olfactory sensor for GI health. I've been on this committee for 5 years. I look forward to today and tomorrow's meetings.
Thank you all. 3 of our committee members, Dr. Hinesh Bansali, Dr. Jay Fieldstein, and Dr. Joshua Lau, are unable to join us for this June meeting, but we want to acknowledge their great work on this committee. Now let's move to our introductory presentation. PTAC members, you will have an opportunity to share any comments or ask any follow-up questions after the presentation. Lee and I served on the Preliminary Comments Development Team, or PCDT, and I've collaborated closely with staff to prepare for this meeting. As the PCDT lead, I will share some of the findings from the analysis to set the stage and goals for this meeting. So let's begin. Good afternoon today. Thank you for joining us on this theme-based discussion on patient safety and its relationship to alternative payment models. Patient safety is one of the most fundamental obligations in healthcare. Every interaction between a patient and the healthcare system carries both opportunity and risk. While medicine has achieved extraordinary advances, preventable harm remains one of the most persistent challenges facing our healthcare system. Today, we will explore not only prevalence and cost of patient harm, but also how payment models, measurement strategies, technology, and organizational design can help us create safer systems of care. I'd like to thank the PCDT team, my co-chair, Dr. Lee Mills, NORC, as well as ASPE for bringing together this presentation and helping with these 2 days. Oh, there we go, sorry. Our discussion today follows 5 themes. First, we'll establish a common understanding of patient safety. We'll review the prevalence and economic burden of patient harm. We'll examine the underlying causes of safety failures and opportunities for improvement. Fourth, we'll discuss how patient safety can and should be measured. And finally, we'll explore how alternative payment models can accelerate meaningful and sustainable improvements in patient safety. Our objective is not simply to describe this problem. Our goal is to identify actionable opportunities over the next 2 days. Specifically, we'll examine how alternative payment models can create stronger incentives for safety where our current measurement systems may be inadequate, how emerging technologies can improve reliability and fidelity to patient safety, and what payment methodologies might best reward organizations that prevent harm rather than merely reacting to it. Patient safety is already deeply embedded in PTAC's work. PTAC has received 36 proposals, of which 28 physician-focused payment model proposals were reviewed in public meetings. 23 were found to meet criteria 9 related to patient safety. This tells us that stakeholders recognize that patient safety is essential. However, recognizing safety and systematically improving it are not the same thing. And today's discussion will focus on how we move from intention to measurable impact. For today's discussion, we are using a practical working definition. Patient safety is freedom from errors that could cause patient harm during the delivery of health care. Errors may be errors of commission, in which an incorrect action was taken, or more importantly, and sometimes even more frequently, errors of omission, in which case a correct action was not taken. This distinction between commission and omission is critical because many of the current safety opportunities in modern healthcare stem not from what was done, but from what was missed. The economic burden of patient harm is staggering. Across OECD countries, preventable harm is estimated to cost more than $600 billion annually. In the United States alone, direct medical costs exceeds billions of dollars each year. Yet the true burden extends far beyond healthcare spending. Patient harm affects productivity, family stability, caregiver burden, workforce participation, disability, as well as quality of life. In many cases, the societal costs exceed the direct medical costs. Patient safety is therefore not only a clinical imperative, it's an economic one. The prevalence of harm is equally sobering. More than 1 in 10 patients globally experiences medical harm. Half of that harm may be preventable. Among hospitalized Medicare beneficiaries, approximately 1 in 4 experiences a harm event, what may be even more concerning is that nearly half of patient harm events may never be captured by what are existing reporting systems. This means that the visible problem may only represent part of the true burden of patient safety. More than 25 years ago, a landmark report, To Err is Human, fundamentally changed the national conversation around patient safety. The report estimated that tens of thousands of Americans were dying each year from preventable medical errors. It catalyzed a generation of safety initiatives. However, recent evidence suggests that improvement has slowed, if not stalled, in recent years. The reality today is that despite enormous effort in the past, preventable harm remains remarkably persistent in our healthcare system. Safety and quality are intertwined. However, they're often discussed separately. In reality, safety is one of the 6 foundational dimensions of healthcare quality as spelled out in STEEP quality domains. The STEEP quality domains include safe care, timely, efficient, equitable, and patient-centered. When safety fails, however, every other dimension of quality is compromised. Therefore, it's very important that we consider safety to be a part of the entire quality continuum. Without safety, quality cannot truly exist. This slide provides perhaps one of the most important frameworks in the presentation. Patient harm does not occur in isolation. It is a systems problem. Systems, human factors, organizational culture, and technology all contribute to safety errors. This encompasses omission errors and commission errors, which result in altered patient outcomes. These factors interact to create opportunities to correct error. Fortunately, mitigation strategies also exist, however, they are significantly underutilized. Communication, standardizing protocols, care coordination, training, improving technology to enable safety, improving patient engagement, and most importantly, a culture of safety, all contribute to the mitigation factors. Improving safety requires strengthening these protective layers simultaneously and not in isolation. Patient safety errors occur across virtually every aspect of the healthcare delivery system. These include medication errors, which account for a large chunk of errors, particularly in transitions. It also encompasses diagnostic, lab, and testing errors, surgical and procedural ones. Outcomes such as healthcare-related errors include infections, falls, pressure injuries. Communication failures are also categorized as safety issues. Historically, healthcare is focused heavily on commission errors because they're easier to identify. However, omission errors may be more common and more difficult to detect, and this is where incentives can play a role. The adverse events framework. This framework helps distinguish several important concepts. It is important to note that not all adverse events are preventable. These are termed as non-controllable adverse events. These occur despite appropriate care. Even with non-controllable events, however, there is an opportunity to rescue the situation and follow up, or regain the patient's trust that is missed to lack of supportive systems. Controllable adverse event represents failures that could potentially have been avoided. Within this group, the most serious are sentinel events and never events. Never event is a very serious preventable sentinel event that should never happen in healthcare, such as wrong side surgery or foreign object left in a patient. When we think about patient harm, we often focus on adverse outcomes. What we miss are near misses. But near misses may be equally valuable, if not more, in patient safety. A near miss is when no harm occurred to the patient. However, there was a potential for harm, and by chance or timely intervention, that harm did not occur. Detection systems of near misses are foundational to any patient safety foundation. Near misses reveal vulnerabilities before a patient is injured and are the events that occur per se below the waterline. They're not seen often in institutions and structures. However, they're of paramount importance to safety, and reporting mechanisms and a safety culture for near misses is very, very important, particularly in systems that have large hierarchical organizations. Organizations with strong safety cultures often learn as much from near misses as they do from actual harm events. This reporting culture tends to lend itself to what are called high reliability cultures. Patient safety has been traditionally supported by a very extensive ecosystem. CMS, AHRQ, CDC, the FDA, the Joint Commission, NCQA, Leapfrog, and IHI. Specifically, CMS ensures mandatory minimum safety standards, conditions of participation in both Medicare and Medicaid. CMS also publicly reports safety data through the Care Compare tool of some of the analytics that we will be seeing later in the presentation. CMS also has administrative alternative payment models that promote patient safety, such as the Hospital Acquired Condition Program. AHRQ is the primary federal agency conducting patient safety research, developing safety measure resources and tools. AHRQ also oversees quality and safety review system to track hospital adverse events. An important component to patient safety today is this hospital adverse event reporting system. Each organization contributes differently. However, together they have created a regulatory measurement, research, and accountability infrastructure that supports safer care, and we can use this mechanism and ecosystem to further the stalling that has happened with patient safety. Moving on to the cost and prevalence of harm events. One of the most important themes emerging in patient safety is a shift beyond hospitals. Historically, safety events have focused primarily on inpatient care. However, much of healthcare now occurs in ambulatory settings. The data shows that preventable adverse events occurs in both environments. Analysis of 11 Massachusetts hospitals found that 1 in 4 of inpatient admissions involved at least one adverse event, 1 in 4. While on the outpatient side, analysis of 11 sites found that 7% of patients had at least one adverse event. Of these events, a quarter were preventable, but 17.4% of them were deemed serious events. The data also points that patient safety does not equally affect all segments of the population. Patients over 65, those with multiple chronic conditions, non-white patients, and patients who are on Medicaid or are uninsured being the most affected. Improvements have occurred due to a variety of factors, including mandatory hospital adoption of standardized safety practices such as hand hygiene protocols and security checklists, financial penalties through value-based care incentive programs such as CMS Hospital's readmission program. Future patient safety strategies and further payment models must address the entire continuum of care, which currently leaves out the outpatient care situations, and include diversity of populations. The next few slides show a remarkable data story. There has been measurable improvement in several safety indicators over time. The chart here shows infection rates across 5 hospital performance quintiles for major healthcare-associated infections. The key message being that large differences in hospital-acquired infections exist between the best and the worst-performing hospitals. The best-performing hospitals consistently achieve dramatically better outcomes than the worst-performing hospitals. These findings emphasize the importance of stronger infection prevention and quality improvement initiatives targeting higher-risk hospitals. This variation matters because it demonstrates that better performance is possible. Next, we see data from the hospital safety results from the CMS Safety Compare tool. The key messages here, as described, is that many patient safety categories improved between 2010 and 2019. There was a blip during the COVID years. However, most indicators have remained relatively stable in recent years. We're starting to now see a decline post-COVID to the norm. However, patient safety events still remain elevated. The importance of this is that while we have put safety guardrails and processes in place, and we have seen incremental gains, overall, there has not been drastic improvement when the healthcare system is viewed in aggregate. As we see in this slide, large and persistent performance gaps exist across hospitals. There's substantial difference in scores between the top and the bottom performers. Top performing hospitals achieve outcomes approximately 25% better than expected. The lowest performing hospitals perform roughly 40% worse than expected. These findings highlight substantial variation in quality and opportunity for improvement across hospital systems. This is observed versus expected, so it has been risk adjusted. A large share of hospitals with poor performance showed limited improvement over time. Nearly half, or 44%, of poorly performing hospitals remained in the bottom tertile throughout this study period. However, approximately 1 in 4 hospitals improved substantially and moved to the top tertile. A substantial portion of high-performing hospitals maintain strong performance over time. However, approximately 20% of initially high-performing hospitals declined to the bottom 3 deciles over time. The key message here and these findings suggest that while performance challenges persist, meaningful performance is achievable. However, maintaining high patient safety performance can be challenging over time, and these results highlight the importance of sustained quality improvement efforts and continuous monitoring, as well as measurement, to preserve these gains in performance and not see slippage. Moving on to patient safety challenges and opportunities. There is no single explanation for causes of safety errors. It is very multifactorial. Healthcare organizations face competing priorities. Measurement systems are retrospective and often lag behind reality. Workforce burnout is a huge problem, and staffing shortages introduce additional risk. Transparency across healthcare organizations remain inconsistent, and many safety systems that are retrospective and designed to identify harm after it occurs do not account for near misses or preventing harm before it occurs. The future of patient safety must be increasingly proactive, predictive, and preventive. When we examine root causes, a consistent pattern emerges. Most patient harm originates not from a single individual failure, but a broader system vulnerability. Poor workflows, fragmented communication, physician and care team burnout, resource constraints, and technology challenges. This insight shifts our focus from blame towards system redesign that can be incentivized, and it incorporates improvement across all of these domains when we look at alternative payment mechanisms. One example of a common illustration of healthcare safety mechanisms is the Swiss cheese model. The Swiss cheese model may be the most recognizable framework today. No single safeguard is perfect. Every layer contains weaknesses. Patient harm occurs when these weaknesses align. The lesson here is powerful. Safer healthcare is built not by expecting perfection from any individual or system, but by designing multiple systems that anticipate human imperfection. Fortunately, we do know that many interventions that work. Standardization in operations, including protocols, structured communication, care coordination, improving patient engagement and patient reporting tools, and safety cultures, particularly with leadership leading safety culture and data analytics. We have to pay particular attention to using the advances in technology as spoken to earlier by both Sam and Abe. Technology can include data analytics, remote monitoring, predictive models that use AI to target high-risk patients. We know who high-risk patients are, and surveillance monitoring. The last and perhaps most important improvement strategy is culture. Encouraging a just culture where reporting is encouraged, not punished, and applauding and is applauded is important in capturing both adverse events as well as near misses. The challenge here is creating incentives and infrastructure necessary to scale these interventions consistently, which leads us to technology. Technology occupies a very unique and more important place in patient safety. Technology can be the cause of harm. There can be direct malfunction. It can contribute to harm, such as non-monitored defaults, burdensome documentation, over-dependence on technology, especially with the implementation of AI. We do risk the burden of over-dependence and workforce interventions that are technological without oversight. However, on a more optimistic note, technology can prevent harm. Artificial intelligence, predictive analytics, remote monitoring, clinical decision support, and interoperability that brings data that's relevant to one place all create opportunities to identify risk before adverse events occur and mitigate them. The question is not whether technology will shape patient safety. The question is how will we deploy it thoughtfully and how will we incentivize it through advanced payment mechanisms. Here I'll speak to two challenges that deserve special emphasis. First, outpatient safety. The IOM's 1999 report focused on medical errors on hospitals, but the volume of care currently is far higher in outpatient settings, particularly with more surgical procedures shifting to outpatient. Tracking safety and creating systems that track safety in the entire healthcare continuum is very important. Second, but not least, errors of omission. This is where the use of technology can perhaps be deployed to surface pertinent medical information that is time-consuming with high potential for error at the point of care. Medication errors commonly account for omission errors. This represents errors such as lack of patient receipt of medication or duplicate medications in transition. Technology can solve these issues in real time, and this deployment is critical. Both of these represent areas where current measurement systems remain underdeveloped and there's an opportunity for improvement. This opportunity can play out with alternative payment models, which may be uniquely positioned to drive this improvement, not just episodically, but over periods of time. Now we look at measurement. As safe care is one of the STEEP measures, we must encompass quality to measure the components of patient safety, including never events, adverse events, and safety processes. What gets measured gets improved. Currently, the gold standard is to do a retrospective chart review. However, automating surveillance using mandatory reporting mechanisms and safety surveys could perhaps get better measurement, particularly patient-related safety surveys. Patient safety measurement must move beyond counting adverse events, and we need a balanced portfolio that includes outcomes, processes, structures, and culture. The strongest safety measures not only measure harm, but the conditions that predict harm. The most common measures used is AHRQ's Patient Safety Indicators, or PSIs, that assess potentially adversable events in hospitals. There are 26 indicators, including 18 provider-level indicators. New measures that exist today are CMS's Patient Safety Structural Measure and ECOS surveys. That shift from retrospective measurement to predictive measurement may be one of the most important advances in patient safety that we've made. Other opportunities for patient safety measurements are CMS's ECQMs, use of data directly extracted from EHRs and HIEs, such as pressure injuries, and reported through the Hospital Inpatient Quality Reporting Tool, or IQR program, and the Medicare Promoting Interoperability Program. CMS has plans to add 2 additional measures as well. The CDC's National Healthcare Safety Network is also creating electronic and automated safety measures called DQMs. These build on ECQMs and are meant to improve validity and decrease reporting burden, and will be reported using HLR7 FHIR standard APIs. Even with these mechanisms, there are challenges that contribute to this being one of the largest problems in healthcare. How do we determine when an adverse event was preventable? Differences in definition of errors, which perhaps represents an opportunity for standardization. Lack of standardized measures. Immature safety measures for outpatient settings. A lag in safety measure information due to reliance on administrative data. And minimal availability of measures of omission. Inclusion of patient-reported measures represents great opportunity. The U.S. results from the 2023 Paris and Medicare Current Beneficiary Survey revealed 13% of primary care patients reported that something went wrong over the course of their care in the last 12 months. This is perhaps one of the greatest opportunities for us to identify errors of omission. Moving on to what the committee has worked to advocate for. Over the next 3 slides, we detail 8 CMS programs or initiatives that have linked performance, including patient safety performance, to payment. The Premier Hospital Quality Incentive demonstration is one. It saw positive results with quality scores increasing almost 19% from 2003 to 2006. One of the programs, the Hospital Readmissions Reduction Program, saw readmission rates decrease, particularly for certain conditions as acute myocardial infarction, heart failure, and pneumonia. Next, we see that the MIPS, or the Merit-Based Incentive Program, CMS-based payment to providers on performance across 4 categories. Patient safety is a MIPS high priority category. It showed that the result of which showed that safety net specialists were more than 30% likely to receive positive payment adjustments than non-safety net specialists. The BPCI-A model resulted in savings. This model also included safety and resulted in savings to Medicare by year 4. What this shows us is that when safety is embedded within quality and included within alternative payment mechanisms, not only do we see improvements in quality, improvements in safety, we also see improvements in savings. TEAM is a new CMS model that will report on specific patient safety measures and will adjust payments based on performance of these measures. In the next 2 days, we will explore approaches to patient safety and alternative payment models. Measuring patient safety in value-based care, improving value-based care through the use of health information technology and data analytics, payment mechanisms and financial incentives to encourage patient safety measures in alternative payment models. I'll close with 3 observations. First, preventable patient harm remains one of healthcare's most significant challenges. Second, the evidence clearly demonstrates that safer care is achievable. And third, alternative payment models offer a unique opportunity to align financial incentives with prevention, reliability, transparency, and accountability. The ultimate goal is not simply fewer errors. It's creating a healthcare system where every patient can trust that safety is embedded into every process, every decision, and every encounter. PTAC members, do you have any follow-up comments or questions for Lee and I? To indicate that you have a comment or question, please flip your name card on its side for our virtual committee members. Please raise your hand on Zoom. And Sam, you're welcome to participate as well. No questions, huh? Larry.
You know I always will have something.
Of course.
Chinny, great presentation. I really enjoyed it, but I just want to expand on a couple of your comments. First of all, technology needs to be utilized better to decrease errors. We need to move our EHRs beyond just documentation tools. They need to help minimize human errors. We need many, many more CDS tools that become part of our process of care. I like your comment about omission errors being more harmful than commission errors. In my experience, they truly are. Errors in misdiagnosis. AI can be an effective tool to help expand our diagnosis and to help us avoid familiarity bias. If we don't think of it, we'll never diagnose it. Communication issues. Technology can help us greatly with communications as providers flip in and out of hospitals depending on their schedules. But one of the things that I think needs to be focused on today is that we need to help providers practice up to the level of their licensure. We today have a very heterogeneous provider profile. We have specialists, we have primary care doctors, we have mid-levels, we have coaches, we have functional doctors, chiropractors, naturopaths. There's a spectrum of providers today. Then layer on top of that the fact that some are employed by hospital systems where we can build processes into them versus the majority of physicians on hospital staffs being independent and really not part of the employed team. We need to build processes so that we can deploy them and minimize the differences among the heterogeneity of the providers. Thanks.
Thank you, Larry. Sam.
Thank you, and thank you for that presentation. I think one of the reasons I'm so excited to hear about the recommendations from this PTAC is that a payment model structured the right way can lead to the type of long-term sustained improvements that you mentioned are sometimes lacking. I would like us to consider that we have a system right now that penalizes for a failure or penalizes for a mistake. And can we consider a model that penalizes for failure to correct? And it's a minor nuance, but I think when we are purely punitive, when we see a penalty, when we measure something specific, we find failure at the system, and we just penalize them and downwardly adjust, it leads to bad behaviors. It leads to hiding, or it leads to focusing on one specific area where we're being asked to improve, and meanwhile we may have an entire system that is failing behind us. If we can focus on something that says, we've identified that you have failure, now you have an opportunity to fix it, and if you don't take steps to fix it, you're leaving money on the table. That will speak, I think, to the financial incentives that leaderships at systems look for, that will make it actually desirable to invest, especially for systems that maybe are just used to being penalized over and over and over again and find themselves in that bottom quartile. I think you pointed out a major gap between the best performing systems and the worst performing systems. So how do we bring the worst performing systems to the table? How do we get them out of that basement that they feel stuck in because they're being penalized over and over again, and maybe they just have no reason to adopt a culture of patient safety, or there's not an incentive to do it. They're not focusing on it. Let's find ways to get them out of that. And I'm really excited to hear about some of the ideas that are being presented for that. So I appreciated your presentation. I think there's a lot we can focus on here.
Thank you, Sam. Lee.
Thanks so much, Cheney. In our investigation of this topic, one of the most fascinating things for me has been we've all recognized, of course, that there's both commission and omission, and different sites of care have different proportions of that. And in ambulatory care, where I've spent most of my career, it's things that you should have done that you didn't do that wind up hurting a patient that are really safety errors. But the really kind of aha moment for me, I'm not sure I've heard talked about any other place, is that the circles of patient safety and the circles of quality and care conversations really are the same thing. They're flip sides of the same coin. Any gap in care, talk about stars or HEDIS performance, any gap in care is a potential safety error of omission. And the whole organization of whether it's a near miss or a controlled adversible event or a never event or a sentinel event, all that tracks. Colorectal screening, a screen that should have happened that didn't happen, is potentially controllable adverse event, all the way down to a late cancer identified with patient harm is a never event. And we don't often talk about them. The financial approach to each, the management approach to each are often completely disconnected in most payer and provider systems. And I just wonder what that means if we think about a new way to turn over a new leaf in this in the country.
And I'll add that as we were doing the data for this presentation and having been involved deeply in risk management in the past, one of the things that often gets overlooked is patient-reported events. And, from the days when I was at DuPage, now Julie Health and Care, we had two mechanisms. We had one where a patient picked up the phone, called us, and complained. That often is not that many, because most people won't pause their time. They move on, especially when there's not been harm, right? So you typically only get that when something has happened. People aren't reporting near misses. But we had implemented a patient survey system where 1 out of 5 patients got surveyed when they left our offices. And looking through those survey comments, we would actually review them weekly with the risk management team. And when you reviewed those survey comments, there was a host of near misses that came from that we then could investigate. And it led to significant changes in our systems and automating them. So I think that patient-reported surveys or passive reporting of comments is really important part of any safety culture, because patients will often tell you, the doctor almost missed this, or this almost happened, or I almost got the wrong report, and those are important. I think we're ready for break. So let's adjourn for break, and we will have a break till 10:40 Eastern Time, and then please. Oh, is it 10:40? Okay, I guess we'll take 10 minutes over. Please join us then as we welcome a great group of experts for our first session, Approaches to Improve Patient Safety in Alternative Payment Models.
Produced by the U.S. Department of Health and Human Services.